Thank you, Rob, for the kind introduction, and to Anna and the Hunter Soul Foundation for organizing this symposium and allowing me to speak to you about newborn screening for Krabbe disease and where we are and where I hope this is going. Next slide, please. I am an employee of the Mayo Clinic. I get a regular salary, which I greatly appreciate. And while we provide apparently services for newborn screening, diagnostic testing, and monitoring for conditions like Krabbe disease, my salary is not tied to any test volumes or specific tests. So next slide, please. This is where we are today when it comes to newborn screening for Krabbe disease in the US and really in the world, because there's no other country where screening for Krabbe disease is currently happening as far as I know. You can see here that New York was the first state in 2006 that added newborn screening for Krabbe. Missouri was the second, Kentucky the third, and most recently it was Pennsylvania. Next slide, please. There are 3 states that have unfunded mandates to actually screen for Krabbe, but because it's unfunded, it hasn't started yet. But the good news, I think, is if you look at the states that already screen for Krabbe, it is more than a quarter of the US baby population that has the benefit of getting the screening. So I think it's probably not too hard to move this forward. If you click again, you can see the situation. Next slide, please. Of newborn screening for lysosomal disorders in the US right now. As everyone hopefully knows, there are 2 lysosomal disorders already on the recommended uniform screening panel, Pompe disease and MPS 1, mucopolysaccharidosis type 1. And Pompe disease is currently screened in all of these states shown here, making up about 63% of all babies in the US. So any of the states that currently screen for Pompe disease using tandem mass spectrometry at least could easily add Krabbe by just adding a reagent and hopefully figuring out an effective and existing way to do a second-tier test. Next slide, please. Kentucky added, again, as I said earlier, as a 3rd state, Krabbe to their screening panel. Again, it was a legislative mandate with really no funding. So the state lab was a little scratching their head how to do it. They reached out to us, next slide please, and asked us whether we could help. And we said yes, but we would really like to also include Pompe disease, which again was already on the RUSP in 2016. And actually on February 15, the first day we received specimens from Kentucky, MPS 1 and ALD were added to the recommended uniform screening panel as well. So we started, however, with the Pompe, MPS 1 and Krabbe at the time. 2 years later, we added ALD for Kentucky. Next slide, please. How do we do this for Kentucky? We actually do what we call a 10-plex assay. That means we're measuring 6 lysosomal enzymes, so not just the 3 for Krabbe, Pompe, and MPS 1, but additional ones, and we measure 4 lysophosphorylcholines for ALD. Now you may wonder, well, why do you do more than is necessary? Well, next slide, please. We're using a bioinformatics tool called CLEAR, which formerly is known as R4S, was developed for newborn screening by my colleague, Dr. Rinaldo. And we're using this for basically a bioinformatic analysis of these 10 analytical data points we get from the screen for every baby. This program also utilizes the birth weight of the baby, the age at collection, and the sex of the baby. And then basically is asked to look, next slide, please, for any idea that the profile that is for each baby could be consistent with Krabbe, MPS 1, Pompe, XALD, or carrier status for XALD. So it does not ask for the diseases associated with the other 3 lysosomal disorders, which are Gaucher disease, Niemann-Pick AB disease, and Fabry disease. So we're not looking for that. We don't apply cutoffs. We don't look at the data. So if any of those results comes back as possibly Krabbe disease, MPS 1, Pompe, or XALD, then we do another test. Next slide, please, where we now look using a dual scatter plot, which basically, when it comes, for example, for the question is whether the baby has Krabbe, it now looks at the baby's profile and compares it to known babies that have Krabbe disease, and to results from blood spots of babies that had false positives for Krabbe disease. And if it still at this point suggests that the baby may have Krabbe disease, then next slide, we do a second-tier test. And that is true for the other conditions as well. For all of those, we have second-tier tests. Next slide. For Krabbe disease, well, what are second-tier tests for those of you who may not know? We think it's a cost-effective way to reduce false positive results, in particular for conditions and markers where there's overlap between the normal healthy population and patients with the disease. So there's poor specificity for that marker. We do this after the primary screen, as I just described, but we use the same specimen. We don't ask for an additional blood spot from the baby. Indeed, the family will never hear about the first result if the second-tier test result is normal. So this is how you reduce false positive results, and therefore a lot of anxiety, because all of you know who know Krabbe disease, no one wants to hear that their baby may have that disease and later find out, well, if you later find out that it's not Krabbe disease, it's probably a big relief, but you shouldn't even have to worry about it if you don't have to. So there are many examples of second-tier tests, either done biochemically or by molecular means. For example, for cystic fibrosis was the first molecular second-tier test. Next slide, please. So for Krabbe disease, we use Psychosine, and for Kentucky, we also look at the 30 kb deletion, which is the best characterized mutation in the GALC gene that causes infantile Krabbe disease if it's present on both chromosomes. But Psychosine is really what is required in our opinion. And what is Psychosine, however? Next slide. So Psychosine is one of the substrates of galactoseroprosidase, which is the enzyme deficient in Krabbe disease. And when it accumulates due to the disease and the deficiency, then it causes neurotoxicity through mechanisms that we don't yet fully understand. But the important part is that it seems to be a biomarker of Krabbe disease when it's elevated, maybe of disease progression, although I'm really not so sure about that anymore. And the other important part is that it's measurable in dried blood spots, which Dr. Orsini and colleagues from Genzyme showed many years ago. And then next slide, please. Working with us, we really put this to the test in newborn screening and showed that it has value. So next slide, when Psychosine, more data on Psychosine, here you can see comparisons of Psychosine levels in patients with Krabbe disease and those that don't have Krabbe disease, either because they're just healthy and don't have any variants in the GALC gene, or have variants that cause what is commonly known as pseudodeficiency, or just carrier for a pathogenic GALC variant. But as you can see here in infantile Krabbe disease, of which we have 36 samples here, Psychosine is really markedly elevated. And note that this is a logarithmic scale. Late infantile Krabbe disease is also elevated compared to normal. We have 29 cases for juvenile Krabbe disease, of which we have only 3 at this point. You can see there's some overlap with normal. So that is something we don't like. I don't know exactly yet how we address this, maybe with more sensitive assays, maybe by using Clear better to tease those cases out. I think we have some options without, again, going back and having a lot of false positives. But overall, I think Psychosine is a game changer when it comes to newborn screening for Krabbe disease. Next slide, please. So if Psychosine is elevated, and in the case of Kentucky, if we found homozygosity for the 30 kb deletion, then that is a screen positive and requires an immediate follow-up if Psychosine is very elevated. So far, and if Psychosine is normal or the 30 kb deletion is not present or just in a carrier state, then it's a normal second-tier test and the screen goes out as negative. Again, no one in that case will hear that we had a low GALC activity, but a normal Psychosine and result. We actually got almost in hot water because Anna, at some point in the second year of screening, called me and said, "Did you miss a Krabbe case in Kentucky?" And I said, "Don't scare me." And what turned out to be that she heard of a mother of a child with Krabbe disease who knew that screening was ongoing, and she expected a call when she had another pregnancy and baby, and she knew the baby was a carrier. So she thought she should hear about it. But again, we're not screening for carriers because those are not going to develop Krabbe disease. Next slide, please. So here are listed just the other second-tier tests that we utilize for the other conditions that we're screening for in Kentucky. It's the same concept. If it's positive, it's positive. If it's negative, the screen overall is negative. Next slide. So this is how it's been going in Kentucky. We screened through June of this year, 294,000 and something babies. We had one positive for Krabbe disease, one of which was true positive. So we didn't have any false positive to date. I'm not aware of any false negative. And so I think that works pretty well. How often did we have to do Psychosine after the clear analysis? Only 73 times, or 1 in 4,000 babies. So basically once a month is how often we have to do it for Kentucky. Next slide, please. So I think it can be done efficiently, effectively, but is it done that way? Next slide, please. If we compare our results in Kentucky to those in other states that reported last year at this meeting, so since I'm going first, I cannot give you updated information. So please, hopefully you will find that the subsequent talks will give you much nicer numbers for the positive predictive value and false positive rate for newborn screening as those programs move ahead. But why do we, or did we have at least, this difference in performance over time? Next slide, please. The problem is, again, really in the way we do the screening. Everyone measures GALC activity. However, Ohio and New Jersey at this point do not have a second-tier test. They have their reasons for it. They try to change that, and I hope they're successful, because right now, if they find low GALC activity, really the physician who's receiving that result has to assume this baby could have infantile Krabbe disease, which is basically an emergency because you need to provide a transplant as soon as possible. So a lot of testing, often unnecessary, is going to happen in these cases. In Missouri, they switched in adding Psychosine to the GALC activity, but I hope they tell you otherwise later, that they don't use GALC anymore in their report when Psychosine is normal. I think until last year, they reported very low GALC activity, even when Psychosine was normal. So a lot of follow-up was still necessary and led to, and basically the false positive. So again, different ways of doing it. Illinois and Tennessee also use Psychosine, but also cannot let go of the genotype necessarily. And again, I hope they will tell you that they have made ways to become more comfortable in screening and reporting. Next slide, please. Last year, we published another paper with many of you out there listening, I assume, which described our experience with Psychosine for screening, diagnosis, and monitoring. And we included this algorithm as to how we feel that screening and follow-up should happen. And as you can see, again, GALC activity is the primary screening assay, then comes Psychosine. And based on the Psychosine result, and next slide, please, the screening laboratories should really then determine how the report goes out, either as normal when Psychosine is normal, or as infantile Krabbe disease when Psychosine is really elevated. Currently, we say about 10 nanomolars. Or if it's between 2 and 10, then it should go out as possible or likely late onset Krabbe disease, which is not an emergency. So you can have a little bit more time in the follow-up, but it still has to happen. But I really, again, my appeal to the screening laboratories is to do what is right and come to a conclusion and not leave the providers with a low GALC activity and a normal Psychosine or a genotype of uncertain significance, which basically leads to unnecessary testing and anxiety because they will do the follow-up testing as if it was a true positive drive the families crazy, but also may not do it in a timely fashion. So babies may not get the opportunity to have the life-saving treatment because after 30 days, there's reluctance in doing a transplant in an infantile Krabbe disease case. Next slide, please. So as Anna mentioned, the Hunter's Hope Foundation tried in 2008 to add Krabbe to the RUSP, but it was declined at that time. Next slide. Dr. Howell, the chair of the advisory committee at the time, sent a friendly letter to Jackie Wagoner and explained to her why the committee decided against adding Krabbe to the RUSP, because there were several gaps they identified in terms of what is actually early infantile Krabbe disease, how do you screen and diagnose it, and how good is really the treatment. So as Anna also mentioned, next slide, a lot of work has been done since. And again, on July 9th, the Hunter's Hope Foundation submitted the renomination of Krabbe disease to the RUSP, where we hope that all of the questions have been answered sufficiently to allow babies the opportunity to be identified through newborn screening and have an opportunity for a life versus a death sentence. Next slide, please. So you will hear more at 1 o'clock from Dr. Orsini about this nomination, from Dr. Kurtzberg about this new newborn screening council, and from Dr. Stone about the guidelines. Next slide, please. And with that, I would like to thank everyone in my lab and all the collaborators over the last decade, I guess. The Hunter's Hope Foundation, in particular, Anna Grantham, for really having a lot of patience in herding the cats or experts to get to the finish line, at least when it comes to the submission. Now we have to see how it goes. I think of Anna more as Anna for granted than Anna Grantham, and really many thanks to her. Thank you.